We are ready, and I just want to say a warm welcome to everybody in the room and also to our online participants. I don't know how many they are, but we have quite a few registered for this event, so hopefully they will join in and can follow this discussion that we will have. So I will just ask you to speak a little bit loud. We have microphones here on the table so they can also hear what we are saying in the room. So we are here today to speak about combining really the rare and neuro space, because it's Rare Disease Day, as most of us know, at the end of the week, and a lot happening in relation to rare disease this week, also here in the Parliament. And we think this was a very good opportunity for us to put on the agenda how the psychological well-being and the psychological aspects really affects rare neurological conditions very much, and we think we need to communicate that clearer and address it more specifically in the approach that we do in terms of providing that support and care for patients. Because there are a lack of efficient therapies for most of the rare diseases, there are a lot of them, and disease-modifying therapies, so they are kind of left to cope with the situation and have symptom management being really the crucial element in the care. And this lack of therapies maybe also is causing a lack of understanding of the needs that is there. We cannot cure, but we can certainly help and alleviate. And this lack of understanding and really how it's being addressed by healthcare providers is causing, I think, a lot of social isolation, stigma, and actually discrimination, I would argue. So, and that's also causing ill health, mentally especially. So it's a bad circle we are in, and we should turn it around. That's what we hope to get out of this room here today, with some kind of measurements or some kind of actions we can think about to try to improve the situation. So thank you so much, Ondřej Dostál, for hosting this meeting. It's very important for us that you are accommodating this opportunity for us as a civil organization to come here representing citizens and have this dialogue, and hopefully some fruitful outcome of it as we move further down the road. So I want to hand over to you to say a few intro words and welcome.
Ladies and gentlemen, thank you very much. In the beginning, let me sound a beautiful Czech greetings to my voters and also to doctors in Czech Republic. Dámy a pánové, dovolte mi pozdravit vás z Evropského parlamentu, jak pacienty s neurologickými nemocemi, tak i lékaře, které zatímco tady mluvíme, pečují o pacienty, včetně Aleny Dernerové, mojí kolegyně a dětské neuroložky. Je velmi důležité, že jsme schopni na této úrovni spolupracovat, mít tedy lidi z celého světa, europoslance, zástupce pacientských sdružení i lékaře, a já bych je teď poprosil, aby pozdravili Českou republiku krátkým hello.
Hello.
Thank you. Okay. Hello. Thank you very much, and back to English because we don't have a translator. So let me introduce our meeting. First of all, we are European Parliament, and at the same time, we have 27 member countries, and we have to speak about what we at the EU level can do for neurological patients. We have several legislation coming up. We have the wonderful cross-border care directive, which is in force for now more than 10 years, but it needs to be actually put into real life, because this is a great instrument for helping patients from countries which do not yet have the healthcare systems equipped enough to take good care, especially about rare diseases, by moving or having the possibility for these patients to move to specialized centers abroad and still have covered by national insurance the treatments which they need. We are working on the enforcement of this act and improving it, so hopefully we will be successful. Secondly, we can help the situation in the area of medicines, because European Union can do a lot in the field of registrations of medicines, of research, clinical testing, and EU budget should support in the area of neurological diseases these activities a lot. Thirdly, we have the wonderful European health data space. We will shortly have my great friend and expert in health law, Tomislav Sokol, who is in charge of this legislation, and he will tell you more about this. But being able to get all the data together, so patient can move from one country to another, from one healthcare facility to another, and still the data is following him. This is a great thing. And another good thing is that it creates a resource of data for research. Of course, we need to safeguard the privacy, but this research on a European level is super important. We also have the new Biotech and new AI Act. And both the field of biotech and artificial intelligence is important both for the patients and doctors, and for the prosperity of European Union and in the world context. So we should see this also as an opportunity. Then we can have the very important reference networks we were speaking about with our colleagues, which allow the doctors to compare what is the best practice to come up with clinical guidelines. And I think EU budget is the perfect resource to fund this. Another area is the activity of patient groups, because doctors and patients need to cooperate, and patients need somebody who will help them in this aspect, and this needs to be done. Finally, let me think a bit in future. At this point, all the healthcare organization has to be done on national level. EU has no competence to decide on prioritizing this or that disease in terms of reimbursement. But some areas like rare diseases would be more efficiently solved on the EU level. So let us think, same as we have so-called 28 regime on business companies, we could have a 28 healthcare systems. Not, of course, for everything, but for the diseases where the common approach, common funding, common diagnostics and treatment would be more efficient than on national level. I don't want to disturb you anymore with my plans and ideas, but perhaps they will take place. We will have our friends from European parliaments and colleagues. We have many experts. So let me now start our event and give the word to the next speakers. Thank you very much.
Thank you so much. Thank you very much for an encouraging intro. And then we will touch more upon specifically also the mental health issues related to rare neurological conditions. And our executive director of EFNA, Orla Galvin, will share the things from the survey we did conduct a year and a half ago.
Yes, thank you so much, Astrid. On the screen, you will see the start of a presentation that will lead into discussions around the data that we received from 560 people living with rare neurological conditions across Europe. But to change up the normal process where we tell you all the data and then tell you what we think we can do, let's look at some of the things that are happening in Europe first, so that you can kind of train your mind to what can we do as a community in collaboration. So to start with, we've already mentioned the European reference networks. For those of you who don't know, they are cross-border networks that bring together hospital centres of expertise who tackle rare and low prevalence complex conditions, which all of up in the room who are familiar with any rare neurological condition know this to be very, very true. We know that there are 24 European reference networks. However, in each country, we do not have 24 European reference network sites. This is an area that we can build upon and grow upon. Next slide, please. Why European reference networks are so important to us in the neurospace is, despite the fact that there are 24 breaking up into different categories of treatment area, of disease area, depending on what way you look at it, 6 of the 24 I don't know how good my maths is, I think that's a 1/4.
25%, yes.
Are reflective of the neurological community. And that's not a small number, and 25% is not rare. Next slide, please. When we consider the environment that rare neurological conditions sit in, we're part of a major ecosystem. So we are here coordinating this event with MEP Dostál because we represent the neurological community, and the rare neuro space and the rare neuro community falls within our remit. And actually, a quarter of our member organizations also represent the rare neurological space. So in order to drive momentum, support for people living with neurological conditions, rare neurological conditions, and very importantly, their families as well, we engage in several activities with several partners, and they're shared on your screen, and you can have access to these slides after. But for now, we will move on. So the next slide, please. Something that is of utmost importance to anyone with a rare neurological condition is getting a proper diagnosis. And once you have that, is there any hope at all for treatment intervention that can adequately manage the condition that you have, the condition that your loved one or family member has? And again, there's a European agency, the European Medicines Agency, that has a very strong influence and factor on whether that is something that can come through or not. And for those of you who are patient advocates in the room, it's really important that you know that you play a role in this process as well. So the Patient and Consumers Working Party, as part of the EMA, was established in 2006. Ahead of that for the healthcare providers, which was established, I think, in 2013. So while we are discussing things today, it's important that you reflect on the role that you may play. Some of you are here as industry representatives, some of you here are representing healthcare professionals, some of you are here representing patient organizations. You have a role to play in this ecosystem, and it's not minor, it's major. Every little counts. Next slide, please. So, as I said, we all have a role to play. We learned from the EMA back in 2006 when they brought patient insight into the process. Yes, doctors can bring the clinical experience, the trial data, the safety input. Patients bring the lived experience, expertise, the true unmet needs, and the real world impact. And together, we learn that we can inform the benefit risk decisions to have the ultimate goal of safer, more effective, and more patient relevant medicines. Next slide, please. So we're coming towards the end of the preamble to the data. But that last point about having meaningful data, meaningful outputs, includes the psychological and well-being of people and families affected by neurological conditions. When we take rare disease as a whole, we see that there were 60 medicines out of 100 and, oh, my math isn't so good, 130 something applications in 2025. 16 were approved in the rare disease space. We had a couple, at least one very definitely neurology, a second one you could maybe put it in the neurology bracket. However, of the 7 negative opinions, we have 1, 2, 3, 4 of the 7 negative opinions in relation to rare neuro. So the challenges are great. Next slide, please. Next slide, please. So the answer to that question is, can you help me? You can, because you're here, and that's step number 1. So the data that we're going to share now is in relation to a survey conducted in 2024. We had 560 respondents who identified as living with a rare neurological condition. If you look at the pie chart on the screen, you can see that actually the major countries represents, Western Europe, the UK, Central Europe with Germany and Italy, and Eastern Europe representing Romania. And the top 3 conditions that were represented are myasthenia gravis, dystonia, and Charcot-Marie-Tooth. Next slide, please. So yes, when it comes to living with rare neurological conditions, there are physical symptoms that are invisible. And earlier we spoke about how the fact that you mightn't identify a single person in this room as having a rare neurological condition. You don't have a label on her forehead. It doesn't present often like that. But some of the commonalities that we see across the board are fatigue, pain, sleep problems, dizziness, balance issues, cognitive problems, GI tract issues, mental health issues, and sexual health problems. And like that, they're not often easy to discuss because they're not often easily visible. Next slide, please. So the non-physical issues people report, again, are great. The top 4, we see over 70% reporting stigma, relationship issues, isolation, and employment issues, followed by education issues and gender-related issues. Each of these issues, again, is invisible, but takes a huge toll on an individual. It takes a huge toll on their relationship with their family, with their friends, with their partners, with their children. And that has a knock-on effect, particularly when we see employment issues adds to financial stress, adds to arguments in the home. Next slide, please. Let's take a deeper dive at the employment and financial issues. We see that over 60% of people with rare neurological conditions have a much more difficult work environment. 70% had to adjust their work to accommodate their condition, and only 40% of people had an employer that was supportive to accommodate this. And behind all of that lives fear. The greatest fear for people was that others would think less of them, that they weren't capable at work, followed by fear of directly losing their job, then by discrimination, which we know is very evident, and then the joint last fear is being made fun of. Imagine that, grown-ups being made fun of in the workplace and for not getting promotions. 32% said it affected the workplace relationships. This, of course, adds to the financial stress. Taking a bigger picture of the finances, we see that 76% said their cost of living went up. Simultaneously, 69% said that their income went down as a direct result of their rare neurological condition. 22% were denied insurance or a mortgage because of their condition, and only 51% have access to a disability benefit. Next slide, please. Social life can have a huge impact, either positive or negative, on our overall well-being and on our mental health. When it comes to social life for people living with rare neurological conditions, 82% indicated that they didn't attend a social or family event as a direct result of their condition. Only 38% indicated that they were comfortable talking about their condition with their family and friends. If you have any other problem, who do you talk to? You talk to your family and friends. This is massive. This is a huge issue. And for parents who live with a rare neurological condition, 16% have been made feel like they're not a good parent, that they shouldn't have become parents because of their condition. Next slide, please. Next slide, please. And finally, then, we come to medical intervention. Here we have, absolutely for all neurological conditions, an issue with health literacy, but for rare neurological conditions, health literacy is even more complicated, even more difficult to address. So the figures on your screen are as a direct result of a lack of health literacy right across Europe. 85% of people indicated that healthcare professionals at times didn't believe the extent or severity of their symptoms. 77% indicated that they believed that they did not receive appropriate treatment because a medical professional did not take them seriously enough. So you have to ask the question, why behind that? And 50% of people indicated that they couldn't describe their symptoms. So how can, if this isn't a, oh, the doctor didn't believe me, this is a, oh my goodness, what can we do to help people explain what they're going through? Help doctors absorb that information. And of course, this then led to 65% of people being initially misdiagnosed, in part at least. Next slide, please. The backdrop of all this is that people living with rare neurological conditions experience stigma nearly every day. When we ask people, what is the reason behind this, do you think? They were asked to prioritize this. And the majority of respondents said that it was owing to the invisible nature of the condition, then a lack of understanding about the condition, the symptoms, because it's neurological, the misconceptions about living with a rare neurological condition, and the name of the condition itself. The area of their life that the stigma has been most problematic, again, a lot of this comes back to health literacy, is the interaction with medical professionals, followed by the employment sector, then with the general public, the interaction with family and friends, in romantic relationships, and then finally during education. An example I gave to the third-year medical students recently was, if you go into a cafe and there's only 2 seats left and you really want to sit down so bad, and there's a person sitting down with a cast on their arm, and there's a person sitting down slurring their words, their movement is a little bit off. You don't have to answer this out loud, but think to yourself, what seat are you going to choose to sit on? Who are you going to sit beside? We really need to break that stigma. Next slide, please. Or are we at the end? Yes. So the last slide is in relation to what our policy asks are, what our recommendations are. And they remain the same as those that were developed from 2003 as part of a multi-stakeholder group across Europe. The Charter recommendations focus on addressing all of these issues that we've outlined. And very importantly, to go back to the beginning of the presentation, there is a huge role for the European reference networks to play. There's a huge role for Europe to play, not alone in the direct healthcare interaction, but in the societal impact, in education, public information, in the implementation of the regulations already around for disability law in employment. And there's a lot we can do, but we do need that coordinated top-level approach to help us in our actions at national level. And with the speakers here today who represent pan-European groups who already know it's important to collaborate across Europe, because in Rare, we don't have the numbers at national level to do it on our own. We have to work together. So thank you very much for your time today. And I know the speakers that you're going to listen to next are really excellent. Thank you so much.
For this important overview. And I want to welcome the 2 additional MEPs into the room. It's an honor for us that you are here. But I think if you have the opportunity to be here for a little more, we will dig into more kind of what does this mean on a more personal level, because we have invited 3 people with representing different diseases. And then we also have a healthcare professional, a specialist in psychology, sharing her thoughts about the importance of and how we can actually help.
This is the president.
Yes.
I'm sorry. Can I ask a specific question to the MEP who just spoke?
Yes.
Thank you.
Very shortly.
Okay. I admire your enthusiasm for your project about European brain data sharing. And I know what I'm talking about because we have an association called European Brain Data Hub. So I know what it is sharing the data and the difficulty of sharing the data. That's one aspect. The other aspect is, as you mentioned, the member states. Member states have to all agree about it. It's not done. Believe me. You know what I'm talking about.
Absolutely. You are so right.
Thank you very much. That's one aspect. So I think it's nice to have very, very, very ambitious. But then, as you mentioned, the member states are not so willing to do it.
No, there are many hurdles.
Neither the patient.
Yeah, there are many
Neither the
hurdles.
patient.
Yeah.
So you have those both difficulties. And the third one is that we are talking about brain and brain disease. Brain is not a priority within the EU budget. So how are you going to cope with all that? Thank you.
But sir, I think we will have some more time for discussion also after we have the presentations, if that's okay, or you have a
You are a German. You are the boss.
Yeah.
Thank you very much.
That's okay. So because we are going from the more overall policy and the data kind of knowledge that we have on this to more personal kind of individual examples, I would argue. And Catalina, you're from Dystonia Group. So please present yourself a little bit more. Who are you?
Yeah, my name is Cynthia Ní. I'm coming from Romania. In Romania, I'm the president of the Association for People with Dystonia. And we are member in the board of Dystonia Europe and board in EFNA through Dystonia Europe. So yeah, I'm having dystonia in the lifetime. I'm also a psychologist, so I experienced that through the experience with dystonia. And I believe that we are having a lot of things to say, but today I will advocate for the patient with dystonia.
What is dystonia? Can you say a little bit more about the disease?
Dystonia is a neurological disorder that it's caused involuntary muscle contraction, and these contractions leading to the twisting, and it's repetitive movements, and put the patients in a, I don't know, in a posture that he can be like straight, but it's also a severe condition. It's not like a physical part that it's the most important. It's it can be invalidated the person that is having dystonia. So yeah, this is the most important aspect. It's repetitive movements, it's involuntary movements, and it's leading to twisting.
And also a lot of pain.
A lot of pain, a lot of fatigue, but I think Orlan's mentioned a lot of things, but for people who are not knowing about dystonia, it's a lot of, I don't know, kind of war inside of the patient, but it's not visible outside. So just the twisting, that's the, what the patient feels inside.
Catalina, can you share a little bit your personal journey in terms of, you waited also a long time for the right diagnosis, I think.
Yeah, I think I wait 1 year and a half to the doctor giving me a diagnosis. So I made a little bit of slide there.
Yeah.
And I think dystonia can, the journey of the patient with dystonia can be divided in 3 stages. I've experienced that, and a lot of patients experience. So the first time it was the symptoms where the patient doesn't know, doesn't understand what he experienced, and where the symptoms that I talked before. And after that, he's searching a lot of answers to the doctors, to the, I don't know, to the family, to all the society, but doesn't get it. So after that, he's coming the progression of the disease, and it stops, and the patient experiences the block. This is the block point where it's very important, because the patient, when he is not getting the right treatment and is waiting for the diagnosis, he experiences a lot of fear and a lot of, I don't know, he's losing the inner power, and he's very confused, and is going to the isolation. And after that, he's going to experience the discrimination and the stigma. And are a lot of patients who are staying in that stage to a lot of time. So yeah, this is the more important point I believe, because if the people with dystonia having access to treatment immediately and access to support, they can stop this block point and can go to the intervention point that I put it there. So that leading to a correct diagnosis, to a treatment access, and after that to improve their quality of life. Yeah. So the most important thing for patients with dystonia and for their mental health is the point that they have needs to support and they don't get it. So I think it's about the support of the medical health, the support of the authorities, I believe, because that's why we're here, and I believe that it's about our dignity like patients. It's not also about the disease itself, you know.
Can I ask you, Katarina, when you finally were diagnosed,
Yeah.
after being this despair and uncertainty for such a long time, what happened? I mean, was it a new doctor, or was it your doctor that finally understood something, or what was kind of the turning point there?
My experience was to meet 12 doctors, 12 neurologists. Yeah. So after that, I go through the block point to isolation and staying there, and I have help by my family. And when I go through that, I've searched for the treatments, and I've received some, I don't know, some information that exists, but not in my country, the treatment. So yeah, the insurance house has to get some connection with our association, and after that we fight for the people with dystonia in our country.
Thank you so much. Anything else you want to add before we pass over to?
I don't know, for me, I think it's simple to understand now the patient with dystonia, and I think the neurological condition, the rare or common, are having a lot of things in common. So I think it's if we are solving the problems of one condition, I think we are solving a lot of problems from different conditions.
Mm-hmm. Thank you so much. Thank you so much. Yes.
What age did you?
At 26. Yeah.
And is it seen to be younger people affected with dystonia that they develop it at that age, or is it normally doesn't really matter what age they are?
It can be from the childhood. It can be genetic. You can develop at I don't know, at any age.
Mm-hmm. So it's something that.
Yeah.
Thank you so much.
You too.
Then we move over to you, Lutgard Allard.
Lut for everybody.
From Myasthenia gravis.
Thank you. My name is Lut. I'm from Belgium. I'm an MG patient for over 30 years.
And when you say MG, it's Myasthenia gravis.
Yes, I excuse. MG is not the car, of course. It's Myasthenia gravis.
I have a car MG.
Yes, see, everybody knows it, but it's Myasthenia gravis, which is not very well known, even not by HEPs. So, what's myasthenia gravis? Well, myasthenia gravis is an autoimmune neuromuscular disease. A mouthful, just to explain what an invisible disease is. Mm-hmm. So, what do we have? We have extreme weak muscles. We have problems not only with our limbs, our hands. We also have problems to chew, to swallow. We have little facial expression. And at the end, we have also breathing problems. So it affects nearly all voluntary muscles, except for the heart. But although that the treatments can have an impact. So what's not only that, we have sometimes a blurred vision, a double vision. We have a slurred speech. So if I don't speak very clearly it's to my MG.
Mhm.
So that's my excuse. Ruby highlights sometimes.
Is it also that the symptoms can vary?
Oh,
from-
yes,
Yeah.
it's so fluctuating. Some days I have a good day, I had a good sleep, I have a good day. But some days it starts from the beginning when I open my eyes. Oh no, it's one of those days. So I go through the day because I have a lot of activities, but I have to be very careful to plan everything very well, take my medication and think ahead what I can skip for that day, because otherwise I will have problems. What means that I can go into a crisis and then it's emergency. And if you are too late, you will end up like Onassis.
Mm.
It was too late and he went into a crisis. So it's still lethal. And we lost 2 years ago a well-known member of a community, a young woman, 31, 2 children, and she went to emergency a few times, and the doctors didn't understand what it was. And she was sent home again. It's not something that happened 30 years ago. It still happens because there are still a lot of misdiagnoses.
Lucy, I'm so sorry for interrupting, but can I please ask the attendees who patients who've travelled distances to get here, can you please just show them the respect and kindness of allowing them to speak? Sorry, Lucy.
Thank you, Lauren. So where I was, it's a chronic disease. So through the stages of your pre-diagnosed or misdiagnosed, diagnosed afterwards, the following up treatments, you need support. Although I thought in the beginning, I fight it. I fight my MG. And the more I fight it, the less I was advancing. I got worse and worse. And the day I accepted my illness, I started getting better. I accept the fact that I was a chronic patient. At that time, you could see because also of my treatment, but I had still a droopy eye and I couldn't laugh anymore. So I had difficulties to speak, and I ended up at the end in emergency after my misdiagnosis. Emergency, not even able to swallow my own saliva. I was so far gone just because of the misdiagnosis. So during the whole process, you need support, especially mental support, because in the beginning, you don't know what happened with your body. You are young, you have your family, you have to take care of your children. So it's a burden. It's anxiety, fear, anxiety. Also a feeling of guilt, because you can't help your loved ones. And it evolves by time, and then come the stigma. You don't have the possibility to do your work, speaking of employment. So there again, you got SLA, you get discriminated because you're working part-time, and they say, oh yes, would we change? You're finished for today. I go home and you're staying. I said, yes, no problem. But we change everything. And then they remember, oh, I said something wrong. But because it's not visible, you're not thinking about it. And that's something I learned out of my own journey. Don't judge people just by seeing them.
Mm-hmm. And you told me yesterday that actually when you quit your job, because finally you had to,
Yes.
they had to put in to do the same job.
Yes.
So you were actually, because the work accommodated for you to work when you were able to, you were very productive actually.
I was very productive,
Yeah.
but at a certain moment the rules change
Mm.
in Belgium, not on European level, but in Belgium. And I had to work fixed hours daily. And before I worked, I won't say on my own convenience, I did my hours in a week, but if I was feeling good, I wouldn't start at 8, I started at 9:30. So, and I stayed longer. But at a certain moment I had to start, and just the pressure of being there every day at the same hour makes my MG worse. So, and I was so productive. that when I left my job, they have to take a full time to do the same job. And even when it was in the beginning of the month, when it was busier, they put another part-time with them. So, but my place, my workplace, has never been adapted to me. I have to adapt to my workplace.
Yeah.
And that should be something that should change. If we could have the opportunity, being people with rare disease, just to present ourselves to employers and show them all over Europe, just make a project out of it to show what we still can do. For me, I was saying COVID came 10 years too late. Remote working wasn't in at the time.
Yeah.
And now everybody knows what remote working is. If I could have worked remote at that time when I got really, really well, I think I would have worked till 65 at least. And now they put me on retirement at 52. Frustrating again, discrimination again.
Well, you are just doing it because Professor Warnke, my colleague, is on Ample Committee actually.
Yeah.
Unemployment Committee.
So that's important.
Well, I would talk if
Yeah.
I made this. Thank you.
Do you have any other messages you want to convey here now? Or we can take it in the more conversation.
Yes. Maybe about things
Yeah.
coming to
Yeah.
me and say,
Yeah.
yes, we have to work and try to adapt places where people can work, and that's something which is important. And also don't judge just by the
Don't
fact.
judge. Mhm. Thank you. Thank you so much. Brings me over to you, Derek.
So I'm Derek Reedman. I'm from Ireland. I currently am on the board of the Huntington Association of Ireland.
What's Huntington's?
4 years ago, I did not ever have heard the word Huntington's until one day I was sitting in a neurologist's office with one of my siblings who was given a diagnosis of Huntington's. And a bit like what you were saying, Orla, around health literacy, my sibling started crying uncontrollably, and the neurologist said, you know, I know this is hard for you to take in. And she said, no, that's not why I'm crying. She says, I'm crying because for the last 10 years, nobody believed what I was telling them.
Really?
And then she had her diagnosis and did not know what Huntington's was.
What was her symptoms? What was she experiencing?
For 10 years, there was a lot of mental health issues at the very beginning. Then there was issues like uncontrolled movements, slurred speech. People thought she was drunk, and various symptoms. And over that 10 years, there was multiple misdiagnoses. At the very beginning, it was this is psychological, it's in your mind. But it went on to this is fibromyalgia, not correct. Multiple misdiagnoses until eventually a test predicted Huntington's is a genetic disorder inherited. Every child of a parent with Huntington's has a 50-50 chance of inheriting Huntington's disease. Now, to describe Huntington's, if you could think of ALS, if you think of Parkinson's, and if you think of Alzheimer's, and you mix the whole lot together, that gives you a clue as to what Huntington's is. It's a fatal neurodegenerative disease. In my family, there are multiple people that actually have now been diagnosed with it, and there are many people that have a negative diagnosis, like myself. But getting a negative diagnosis does not in any way take away the health implications of the mental health issues, because a lot of children become carers for their parents if they when they develop Huntington's. Now, back in January 2022, the first thing we did is Google or go on, take out your phone and have a look and type into your phone, what's the cruelest inherited disease? And the answer on all of them is going to be Huntington's disease. And then the first thing that we decided is who can give us help? So there are, at the time, no services at all for Huntington's disease in Ireland. There was no public service at all. Now, 4 years later, we have one specialist Huntington's nurse in Ireland, and that's fine. But when you talk about stigma, a lack of public services, lack of awareness, perpetuates stigma. You know, when people don't know about an illness, that makes them afraid of it, and it creates stigma. As I was saying earlier, when my sibling was many times told people thought she was drunk. It's very difficult.
So when she was finally diagnosed with a lethal neurodegenerative severe disease, what was she offered?
At the very beginning, the first thing that we offered was, we'll bring you back for a neuro appointment in 3 months. So when we went out, so as I said, there were no services. But what there was the Huntington's Disease Association of Ireland, which was propping up all of the Huntington's patients in the country and providing that support. And it was only through the Huntington's Disease Association of Ireland that we were able to understand what supports we needed. You know, what supports did you need? And the supports that are needed are multidisciplinary supports. There's occupational therapy, physiotherapy, there's mental health, there's psychiatry, psychology. It goes on. It's everything. We need a multidisciplinary approach. And interestingly, over the last few years, I've got to know people in different European countries. So Portugal, very similar to Ireland. You know, very few services. But we look over that fence at the Netherlands and we see brilliant service that they have. They may say they need to improve it, but they have multidisciplinary teams around the country. The same with Scotland, who is the same population as Ireland, and they have 10 multidisciplinary teams specifically for Huntington's disease. You know, there's across Europe, there's no consistency in services that are provided. That's one of the things that we would like to see, the more cohesive approach exactly to rare diseases. And everything I say about Huntington's, it also applies to other rare diseases, which I've discovered over many meetings, especially last year when I was on the community advisory board for Etna and met many other people in the rare disease space. Those issues apply across the board. And when we talk about mental health, which is what we're focusing on here, mental health starts way before a diagnosis of a rare disease. And in the case of my family, you're looking at mental health issues 10 years before a diagnosis.
How is your sibling doing now?
Well, she's at a
Better
fairly-
place or?
Well, she has the services and supports, but that was something that had to be explored for many years or 3 years to actually get. It's not something that was provided free of charge or you know, easily. It's something you have to fight for. I see this with other rare diseases in Ireland as well. People have to fight and fight and fight every single time to get the service that they want. It's not something that's offered to you. It's something that you have to fight for. You spend a long time, lots of energy fighting. And that affects the mental health of everybody involved across the families.
Yeah. Thank you so much, Derek, for sharing all that. And you bring me nicely over to you, Tonya, I think, because you talk about the importance of the multidisciplinary approach. And you work at the Habilitation Center or a rare disease center in Norway as a psychologist.
Yes, yeah. And so this is a topic that I could talk about all day. So I have to think very long and hard about what is going to be my main point today. And actually, I'm going to talk about finance, which may be a little surprising coming from a psychologist. But actually, I'm going to explain myself. So my main point is that focusing on mental health and neurological conditions is something that will make our healthcare systems more cost effective. And there are several reasons for that. First of all, is that mental illness directly affects physical health. So mental illness often encompasses disturbances in sleep, in appetite, in activity levels, as well as causing lots of physiological stress on the body. And we do not want our patients with neurological conditions to not sleep well or eat well or be active. That's very important. It's also that mental illness affects adherence to medical treatment. So our anxious and depressed patients, they do not follow up with their doctor's appointment, for instance, or they do not take medications as prescribed, for instance. So it directly affects medical treatment that way. It also affects the effectiveness of the medical treatments because a depressed patient will have difficulty following up on, for instance, physical therapy. It's not easy to do the training program if you are lacking motivation and lacking energy and those types of things. So that's important as well. So, and also research actually shows that psychological interventions can slow down disease progression as well, as in one study showing MRI results of patients receiving cognitive behavioral therapy had decelerated fatty infiltrations of the muscles in people with muscular dystrophy, as opposed to patients just receiving physical therapy. So it has a direct physical effect on the body as well. So to summarize, patients may receive the best medical care that money can buy, but do not have the intended effectiveness of that treatment because mental illness stands in the way of the effectiveness of the treatments. Instead, when you think about treatment in a multidisciplinary way, which also entails psychological treatments, then we can give the right treatments at the right time, and thereby enhancing the effectiveness and giving us a much more cost-effective health care system across the line. Yeah. That is my main focus, given the context that we're in today. Yeah.
Can I ask you, based on your experience in your work or the research, you know, what are the main things that people affected by a neurological condition is facing mentally? I mean, do you have any kind of pattern you see, or where kind of the psychological support can really be a key to help?
Yeah, so definitely at the time of diagnosis is a big point of where you can support people. Many stories we hear here today is very, many of my patients describe that being in a vacuum, having a diagnosis and having your neurological assessment 3 months later. And this is where mental health professionals can be a big help.
What do you do then?
Well, it's very individual what each person needs in a situation like that. Yeah. But I would say that making sure that you work with the entire family, not just the patient, but also the partner, the parents, the siblings as well are very affected, both adult siblings and also children, because this is our patients' primary support system. So getting them into the picture, making sure everybody knows about the disease, destigmatization, psychoeducation, learning about the disease, but also learning about mental health, because I've yet to meet a singular patient who has received a diagnosis of a rare disorder and not reacting psychologically at all. I mean, that would probably be more alarming if someone was completely neutral. So making sure people know about what are the normal reactions to being in a normal situation of receiving this potentially catastrophic diagnosis like you did. Yeah, that's would be their main. And knowing about the resources is also very important. Many people describe it as being dropped in a jungle, and you don't know what are your rights, what are the resources available to you, and that's especially when it comes to the rare disease world, of course, with less resources than your more major neurological conditions.
So do I understand you correct? I would argue that receiving a diagnosis for many of these diseases is definitely a crisis in a person's life.
Absolutely.
And you know, when I look at television in Norway, maybe it's all over Europe, I'm not sure. But anyway, when there has been an accident, somebody has, you know, been brutally, you know, harmed in an accident or died and whatever. And there is the crisis team coming up, helping people. The churches are open, come help. Let's process this together. But people who receive this kind of crisis all the time,
Fantastic.
there is no system thinking about it. Do you have any thoughts about why?
Yes, I think that there's part of it's cultural, and that you don't talk about illness. That's a part of it's private, it's something you don't talk about, and that's one thing I think is about to change, but still it's considered a very private event. We have to end that, I think, is a big thing, yes. But we definitely are talking about it now in Norway, that on the same degree that you have a crisis team for car accidents or natural disasters, you should have a crisis team standing by for when a person gets a potentially devastating diagnosis, either themselves or their children. Also, there should be a system set in place, and often it's also about the communication between in Norway, especially between hospitals and where the person lives, because that can be a long distance from where you get your rare diagnosis, maybe in a national center, and then you go to your hometown, which is hours and hours away. So there has to be a communication between local services and specialized services for this to happen as well. Yeah, because you always, when patients tell me all the time that people around them say, just contact me if there is anything. Yeah. But often patients don't have that in them to have the initiative to reach out. We have to reach out to them. But because when you're in a crisis like that, you don't always know where to call, what to say. Like you said, how do I describe my symptoms? It's very hard to describe a situation like that to someone else. Yeah.
Thank you so much. I wonder if we are at a point where we should give you the opportunity here as MEPs to say a few words, if you would like to.
Yeah. Yes.
Yes.
Oh, yes.
Oh, yes, you are ready. Help us. How can we move this space forward?
No.
Okay.
Okay.
Please introduce yourself.
Okay, yeah.
Yes.
I'm from Germany. My name is Jan Warnke, and I'm a professor for neurosurgery from Germany. I was there for 40 years.
Mm-hmm.
And I'm not a politician.
But you're here in the parliament.
I'm a citizen elected into a parliament. May I give you that difference, you know, and hopefully for 5 years, and that's it. So, I exactly know what you are talking about, because as a neurosurgeon, I've been dealing with rare diseases. In my specialty, there are a few rare diseases, but the one I have been dealing with for decades is arachnoiditis and Tarlov cysts. This is something very, very special. It is an autoimmune aggressive inflammation of the central nervous system surrounding sheath, the leptomeningeals. And it's like a harlequin what the symptoms regards, and the severity of symptoms regards. And we founded a non-profit research organization, the so-called Victus Thomsen Foundation, named after a Norwegian patient who donated to that research work in a remarkable amount of money. And we made a foundation out of that. And the major problem I saw with all these patients coming not only from Germany, a few figures. Germany has 88 million inhabitants. We think there are 400,000 patients potentially with different symptoms, and symptomatics out of them are 20,000. And the medical community does not accept this as a diagnosis. And with the patients I met during my lifespan as a neurosurgeon, the biggest tragedy was that the patients were telling me, my doctor did not believe me.
Yeah.
And from that point, the whole catastrophe started, including the social isolation, the problems in the marriages, the problems with working places, and all that. Because the symptoms of this special disease is very varying in the extent and in the severity. And I have seen patients having second course of psychotherapy regarding of their mental problems, but the cause was a Tarlov cyst in the sacral bone.
Mm-hmm.
And the ignorance of my fellow colleagues as a doctors is the main problem I found, and this is I'm to fight for here in the parliament, the awareness of doctors regarding rare diseases. So I do fully understand what you are talking about. It fits into my experience 110%.
So from this position that we have now then,
Yeah.
in this parliament, do you see any pathways, any policies? Do you see anything that we can do together to improve this situation?
Absolutely.
Because knowledge is definitely one thing, but what else?
Knowledge and the spreading of knowledge is the other thing. Acquiring data for common research. If you see the incidence of this arachnoiditis Tarlov cyst in Germany, and if you reckon how many patients that will be in Estonia, having 1.3 million inhabitants means that we have to collect all this data. So a European database on specific rare diseases would be from great help. Registry, and then work up of the data we have been collecting. This is a major point.
Mm-hmm. Thank
And the average time between the beginning of symptoms and the recognition of the diagnosis was 8 years.
you.
May I say something to that? Can you explain to me, Dr., why there is a big difference between women receiving the diagnosis and men?
In the time.
In the time, because, and it's one of the data that came out of the Rare Barometer of Rhodes, and that's because doctors, I would say they don't listen, they listen, but they are putting, especially young women, in the corner of it's mental.
My experience, 100%.
And I went for 9 months to humiliation.
Mm-hmm.
You want to be in the spotlight. What are you doing to your family or whatever? And when I went into emergency to have my diagnosis, if they told me at that moment, you have ALS and will live for another 2-3 days, I would have been happy, just to prove it wasn't mental.
Yeah, absolutely. Yeah, 100%. I agree. That's my experience.
Do you want to add anything? No, Nina?
Thank you very much, and thank you for hosting MEP Dostál. Thank you very much, and thank you very much for EFNA for being here today as well. I want to thank Kathleen and Derek and Mr. Derek for coming and telling me your experiences. I suppose we all have our reasons why we're here in this intergroup. Me personally, I'm off the back of my mum having Alzheimer's, my dad having dementia, and my granny having Alzheimer's, but I'm here to learn about all these other different rare diseases, neurological diseases here, and I can't imagine
what it would have been like for getting my dad diagnosed with dementia and my mother, and not knowing what they had. I can't imagine what that would have felt like with the stress involved, even knowing they had this type of disease. But can you imagine how long I suppose anxiety would have went on for if we didn't have that? I suppose so many people living with Alzheimer's and dementia anyway. So I'm hearing you there, and I think we need to do more. I'm on the budget committee, and I feel very passionate about. We've lots of money going into the next Horizon Fund, and I do think there's an opportunity there to really put an earmarking of brain health, not just obviously looking at dementia or Alzheimer's, looking at the whole brain health issue. And I do think this is what I'm advocating for. I think Cancer Mission has been a huge success in that Horizon Fund, and I do think brain health should have its own section on earmarking in the next MFF, and I'm sure all the other MEPs will be backing me up on that. And I put in amendments to it, so I'm sure we get a lot of MEPs in behind that and leading out. But that's what it's about. It's about being here and raising our voices. And now I have lots more, I suppose, examples of bringing it to the table and backing it up. And the more times we can ask for plenary in time to speak, I think that gives us a chance to obviously stay at home and keep bringing it to the table and raising it, because otherwise we don't have this platform. How else are we going to achieve? So that's really what I want to do.
We are definitely behind you on that.
But I feel that's what I can do practically. Obviously, from Alzheimer's and dementia, I feel like what I can try to achieve at home is trying to bring all the organisations together in the one room and say, this is what is available for you. Obviously, I'd love to do it for Huntington's and whatever, but maybe we can get down that route eventually when we can work with Huntington's, or, you know, obviously Alzheimer's is a very established disease and a lot of people are living with it. But we have to recognise the other challenges we have with neurological diseases as well. And maybe that's something we could look at in Ireland and kind of have those info nights. So maybe that's my contribution to this hope and trying to achieve a brain health mission in the Horizon Fund, which we know it's been doubled, so we need to grab that money and use it for brain health.
No, thank you so much. That's very encouraging. We understand the reality of politics, but we really appreciate this position that you're taking and that you are encouraging colleagues to support this. And I think when you talk about disease-specific strategies, we understand also that we cannot have a strategy or a plan for each disease in every space, but we can see it in a combination because we benefit from so much of the same kind of thinking around how we read the services that is needed. So I think that's excellent. Sorry, just a second. We have also Paul is not here yet, and maybe he's coming later. I don't know.
Yes, so Mr. Sokol should come a bit late, like at the very end of the meeting, and Ms. Ní Mhurchú should be arriving also, like at the.
Yeah, but because there was a question, I think, or a comment, but I would like to have also Billy Kelleher, the videos. So yes. Maybe we can take that first.
Yes.
And then we can see it. Then we will have some time.
Hello, I'm sorry for not being able to take part in today's discussion, but I want to thank EFNA for supporting the work of the Intergroup and continuing to shine a light on these important topics. Rare neurological conditions may be individually rare, but their collective impact is significant. Neurological diseases are a leading cause of disability, affecting 1 in 3 people, and rare neurological conditions represent a significant proportion of them. Yet access to diagnosis, treatment, specialist care and social support remains deeply unequal across our member states. Today, where a person lives in Europe can determine how long they wait for a diagnosis, whether they have access to multidisciplinary expertise, whether rehabilitation is available, and whether mental health support is integrated into their care. It can determine whether they are able to stay in employment or are pushed into early retirement. This is not acceptable. Equity in neurological care must be a European priority. I really welcome the discussion today, which highlights the impact of these conditions on mental health and well-being. Rare neurological conditions are not only medical diagnoses, they reshape every dimension of life and can often be very isolating or lead to social withdrawal. Stigma also remains a serious challenge. Too many individuals report being disbelieved or labelled as difficult. This exclusion only fuels anxiety and depression among patients. Naturally, they also deeply affect the families and loved ones of those who are suffering with the conditions. It is important to point out the enormous responsibilities of informal carers in our society. Too often they need to shoulder this responsibility, often without adequate support. They face financial strain, emotional pressure and uncertainty about the future. The burden of rare neurological conditions is therefore not only clinical, it is social, economic and structural. This vicious circle makes it clear that mental health must not be treated as an afterthought. It must be fully embedded in neurological care pathways from diagnosis onwards. It is clear to me that we must also adopt a life course approach. Rare neurological conditions can present at birth, emerge in childhood, develop in early adulthood or appear later in life. Care cannot stop at diagnosis. We need timely referral systems, coordinated multidisciplinary follow-up, smooth transitions from paediatric to adult services and adequate support for people ageing with neurological conditions. Continuity of care is essential for both physical and mental well-being. European collaboration has a key role to play through funding, through research and through prioritisation. It is heartening to see the neurological diseases are gaining more traction in European policy sphere. Just this week, the SAN Committee held a public hearing on neurological health. We need to build on this momentum and ensure that neurological health is duly recognised in Europe's health agenda and work to ensure equal access to care and treatment, as well as support across the EU. Thank you.
Okay, good. I think we can agree that we agree on quite a lot of things actually, on what's needing to be done, and then it's about how. How and when, yeah, we are in a hurry, yeah. And there we have a welcome. Please, we have a seat for you here, yes.
Excuse me.
Welcome, Cynthia. We are being so quiet when you enter the room. It's really an honor for us to have you here.
Well, it's an honor for me to be here. Thank you very much for being here.
And I think Ireland is doing very well. But I don't know if you want to say something. We have just had a round from the MEPs again. You can listen in, obviously, because you are busy. We really understand that. But do you have a few words you want to say? Or
I'd love to. I hope it's too long now. But sorry, I was at another committee meeting, the European Democracy Shield. So good afternoon, everybody. My apologies for being late. Thank you. I hope your visit to the house is going well.
Yes.
Yes, and I hope you're being well received.
Yes, we are
getting
very much
good and getting a listening ear. So apart from saying and all of that, just to say that I mean, I want to congratulate you on your fantastic work and all your advocacy and all your hard grit, everything that you do. And I know that you work tirelessly, especially our European Federation of Neurological Associations and so forth. And I'm pleased to say that I'll be involved hopefully in your inaugural conference in September, and I'm really looking forward to that in Ireland. I'm an MEP from Ireland South, like Nina. I'm from Ireland as well. And we have different constituencies, but we both are very much supportive of people with rare neurological conditions, because obviously our voters, when we meet them, they invariably have either some sort of a condition themselves or they have a family member who needs help. And it's not easy to get help, as you know. So I suppose since I got elected, I'm very much aware that across Europe there are millions of people living with rare diseases. And this is not just an insignificant number of people. And these conditions are complex. They're not the same for everyone, and they're life-altering. So it doesn't mean that you can just get better fast or even get better slow. It's something that sometimes can get progressively worse, and the care needs and requirements change. So I'm also aware that there can be a delay in diagnosis and there can be a misdiagnosis. And then obviously invariably when that happens, that can lead to people feeling unheard misunderstood, I should say, not understood correctly. And that's another dimension then that takes a huge toll on somebody's mental health, as well as obviously dealing with other symptoms. So I do appreciate the psychological toll can be immense. So you do need advocates, and I'm pleased to see that you have advocates for you and supporters for you in the house. And it's very important that you know that, and that you lean on our offices, reach out and lean, and that you ask us to do as much as we can do, or what we can do for you. I just want to mention about children and young people, because it's particularly pernicious and difficult for them with these rare kinds of diseases, because obviously they can be bullied, because that's what happens at a certain stage in your life. It's just there as a culture, and their education can be interrupted as well. And that's very difficult as you try and progress in life. And also then very much appreciate, and I'm very impressed by the caregivers that I see in Ireland, in my constituency in Ireland South, that are working tirelessly. A lot of them unsung heroes of their community, of their town, of their village, but very important. So I'm aware as well that of the extraordinary work that the charities do, the neurological charities, and I'm aware of the work, I should say tangentially, because I haven't visited these in person to meet with the organisers, but I am aware of the organisations like Neurological Alliance of Ireland, Epilepsy Ireland also, MS Ireland, and indeed the FND Hope Foundation. So these are all very important, not just in relation to advocacy and raising awareness, but also in providing services, because quite frankly, I have met families dealing with those who have conditions and they're exhausted. You know, they can put up the good fight for so long, but it does lead to exhaustion, and it does lead to isolation. So the European Health Union, it's really important that it's here, that it works for you, and that there's a bigger umbrella group working together with our individual groups in our individual countries in Europe. And I suppose the EU's pharmaceutical and research frameworks, we have to continue to support them as well. That's very important. I'm working on a couple of medtech files at the moment. I'm just only starting. I'm not saying they're going to touch necessarily upon neurological conditions, but I will find out, and I hope they do. And I'd certainly be trying to create some synergy there. I think our mental health strategies, we need to explicitly call out, and we need to block off or have a particular aspect of it that includes those living with chronic and rare conditions, because I think it is particularly pernicious, the mental health difficulties. I've mentioned that already for people who do suffer from these types of conditions. And of course, we need a much more integrated system, because frequently I hear from voters and families and people looking for help, and they're jumped, as we say in Ireland, from Billy to Jack. Or from Mary to Annie, you know, they're both from the neurologist, who doesn't link up necessarily with the psychologist, or with the psychiatrist, or with the social worker, or with the community nurse, or, you know, so you're constantly trying to put together the patchwork quilt. So we really need to listen. We need to listen to your good selves, and we need to listen to people with neurological difficulties, to patients. So I do want to make particular, I suppose, reference to EFNA. Met you some time ago, very impressed by your work, and thank you for everything. And I'm so pleased that you've chosen Ireland for the inaugural conference in September. I'm sure it's going to be a huge success. And I know that, is it Cyprus after that, or Malta, excuse me, 2 years later, will lead out. Because we need to have such a big exposure on a big European stage during a European presidency, because these conditions carry stigma. And unfortunately, some people then, not only do they close their ears, but they close off their mind as well, you know, and they tend to say, oh, somebody else will sort that out. So we have to remove that stigma of, it's not my problem, it's somebody else's. So I'm acutely aware, I suppose, as a member of the Parliament, representing people and needing votes to get into office, I'm increasingly aware and proud of communities that we represent. And it's the power of the community. But I'm also acutely aware that volunteerism and communities coming together can only do so much, because it does lead to burnout and it does lead to exhaustion. So I just want you to know that I'm here in my political group called Renew Europe. And Nina, of course, is an EPP, which is great. So you've got two big groups in the House, and then you've got two big political parties back home in Ireland, who are here in solidarity with you. And I'm sure there are other MEPs. I'm sorry, I've probably left somebody out. I know that. Yes. I'm sorry. I'm so sorry.
From which party are you?
We are not. We are these non-politicians who are here just on a holiday.
Stop saying. You're being coy.
We are right.
But isn't it great that across the House, across the Parliament, across the governments of Europe, that you can get this solidarity, because that is really important. So I do want to advocate for stronger EU action in this whole area, and I remain constantly open. My office is open to listen to what needs to be done, where and when, to whom, with whom, how, and how can we build up that solidarity so that we can get your results. Because it's not just all about highlighting the problem. It's about saying, this is the solution, this is how we need to work towards the solution, and this is who we need MEPs to talk to. So, all I want to say is, Berimish Bula Kéla agus I Breamish Kéla, which is my Irish way of saying, because sometimes I think in Irish, it's my way of saying, let's win together, you know, let's strive together, and let's work together, because that is so important. And I want to wish you all the very best. I'm sorry I'm missing out on all of your meeting, most of your meeting, but thank you for the opportunity just for me to introduce myself. I'm sorry that I don't have an opportunity to remain and get introduced or be introduced to everybody else, but no doubt India, who's with me in my office, she'll brief me up. She's given me a great brief, and we'll have a chat about this afterwards, and you know, she'll fill in the blanks that I have, because it is important that we build up personal alliances, professional personal alliances, like in a room like this, rather than all the time emails or you know, on our Teams or Zoom call. So thank you very much. Let's keep working together, and I just wish you all the very best of luck. For Amila Mahdi. Thank you.
Thank you. Thank you. So thank you. You really touched upon most of the points that we have discussed or talked about here during the conversations we've had here. So again, I think the broad kind of political spectrum that is represented in this room and in the support for the interest group that we also have is super important to us. This is not a left or a right or whatever. This is a human thing to improve the health of your citizens. So that's very much appreciated. I wonder, we have come to soon to close, or what's happening?
So MEP Sokol, I'm sorry, mentioned that he would come at 3:50. So I guess
we still have time. I'm sorry.
Our meeting is until 4. It was envisioned as a networking and discussing. Yeah. So it's until 2 to 4. We always put in a little bit of buffer time as well. Yeah. For people to settle in, so we can still have a discussion.
For your discussion, absolutely excellent.
Some question which we delegated to the end of the meeting, so we
yeah.
So maybe I can.
Well, I'm Nina Carberry. I'm the president of Cervical Brain Tumor, and a brain tumor, it's a neurological condition, but it's also a cancer. From the cancer part, we have a multidisciplinary committee that's talking about the patients. We have psychological support, but I think that also is needed for people living with neurological conditions. Multidisciplinary team and psychological support. And in Europe, we have a cancer plan. Perhaps we need also a European brain plan. Therefore, we need numbers. We need a register, isn't it?
Yes, indeed. We have no register in Belgium. There was an article in the journal saying Belgium and Belarus are the two countries where there is no register of ABC, of stroke.
So we need to know where the patients are. That's what you're saying in terms of register.
Do you have a question at the beginning?
Yeah. Maybe I can come back to the need, the problem. Yes. Because I appreciate very much all you said.
Maybe you could present yourself.
Okay. So my name is Roland Pochet. I am the CEO of the NGO called the Belgian Brain Council, the well-known BBC. And we created, because of this lack of registry, we created 1 year ago international association called the European Brain Data Hub, because we used a law, EU law called the Data Governance. So we just claim that we need that. This data, we can do a lot more things. We can feed the AI and speed up everything. It's well recognized. We don't discuss it, but you need the data.
That's right.
Yes, and health data. And this the law, and the law say you can have a data altruist association. We created, and we are recognized by EU. It's not so easy, but we are recognized. We are only 2 countries in Europe yet. And with this, we start the concept. The patient is ready to share his data, but he has not data, and he's the only one who can decide to share. No one else. So I'm ready to share the data, but my data, where are they? Oh, they are in lockers, in hospitals, in pharmacists, in psychologists, in different institutions. But they cannot communicate between them until I approve.
What's your question?
Okay. My question is about the fact that there is a lack of means to progress in research on brain. And the Commission has not put the priority on brain. So we are locked. We are blocked. It's not a question, it's just a fact. Maybe MEP can influence because they decide on the budget.
Well, it is not so bad. Actually, we do have a law to share data. It is in the patient directive, patient movement directive from 2014. Every patient should actually have a patient summary. So if the patient goes abroad, it should automatically go with him. We also have the possibility to share the anonymized medical data. It is not prohibited by anything. We also have the law from forever, 20 years ago, that every patient can request the data from all these lockers, and all these lockers have to give it to the patients until the other health lawyer arrives. Tomislav Sokol from Croatia was doing health law in Czech Republic. So it enables every patient to get the data, provide it to the researchers, go abroad to Professor Warnke's clinic or to some other place. The problem is that we have still the nation systems who pay for the treatment, but the European framework, which we want to do into a health union. So it is organized confusion, and nobody can raise successfully the organized confusion, like our esteemed colleague. But for the patients, it's very hard. So they need somebody who would support them. And these can be the patient groups, and in the budget, we can have enough money to support the patient groups who help the patient to go through the confusion. And we also need to get through the European health data space, which Tomislav will speak about. And then I think we will have the means for the research you need, actually. But those of you who are in closer relations with budgets or with the Commission, it is good to sometimes to go to Varhely, the Commissioner, to actually implement the laws we already have. I was speaking with the people at the Commission; they are quite eager, but they, on many occasions, they just don't know what is happening. So if we tell them, please tell the states to enforce the legislation we have for 10 or 20 years, then it will improve the conditions.
Maybe could we, since we have some time, could we talk a little bit about the role of the patient organizations, being European federations or umbrellas or national organizations? Because I think all of you mentioned the importance as patients or as family members, the importance of the association in pointing the way and finding the resources and being there and advocate for the needs, obviously, which we definitely do on the European level as well. So how do you think as politicians that, because we receive very little support, if you understand, to enable us to do that, it's limited what we can rely on from the volunteer basis because people are exhausted when they're taking care of their life and the disease and everything. So are there means that we could improve the situation for patient organizations to play the role everybody wants us to play, and we want to play them as well, you know, in relation to everything that's going on in our space. But we are drawn so upon our resources. Do you have any thoughts about that?
May I say there is a big difference between European Patient Association and national patient in terms of budget, because the National Brain Association, you don't get a penny from their state. That's the first difficulty, because when you deal with patients, you have to first speak their language. And it's nice to have a European Brain Association, but the patient doesn't speak English, or we are a minority. That's the first problem. The second problem is that you have to better educate the patient association, because their role is also to transmit the knowledge to the patient. And this is because National Brain Association are very weak, and it's volunteers, and it's they don't have always a...
Believe me, that's the case for all of us. Really, that's the case for all of us.
Makes no difference.
No, it doesn't.
At the European level, and we don't receive a penny from the national and not a penny of Europe. We are just functioning by volunteers who are working much too much. And from time to time, to be honest, we work together with the pharmaceutical industry, because otherwise we wouldn't be able to do anything. The second problem with the European Association in Belgium is that you have to be holier than the Pope to have an existence here, and you have to have proofs for everything, even to open a bank account. We need someone here. Luckily, I'm from Belgium, but otherwise we couldn't work. And that's Europe. So be sure you're better off than Europe.
Maybe a push. Orla has something. Do you want to add something?
Yeah. In my experience, patient organizations are sometimes the last hope for the patients. Because the doctors ignore them. And I wanted to add why doctors ignore them. That's a question, huh?
Yeah.
Why can doctors ignore patients' symptoms and find a diagnosis? It's very easy. It's inside the psychology of medical doctors. A disease which I do not know does not exist. It is as simple as that.
Or it's a mental disease.
Okay, then it is a mental disease. Yeah. But this has to do with the structure of medical doctors. I very self-critically, because as you know, I'm a medical doctor, but that is the only explanation which I can think of. Something which I do not know does not exist. And these patient organizations play an enormous role. They give the patients the hope sometimes. They give them the hope not to give up, not to surrender, not to commit suicide. Because this is the association of people with the same problem, with the same suffering, with the same trouble. And how to strengthen those patient organizations, that's a very interesting question. And you are right, MEPs should work on that.
Somebody said yesterday, the mind doesn't believe what the eye doesn't see. I think that's what you're saying. We will have our blind spots, and doctors definitely as well.
Yeah.
But Orla, you had something you wanted to comment on.
So I think oftentimes patient organizations are misinterpreted as, oh, we want to come and get some policy that can give us some finances, when the fact that we have MEPs in the room from Central, Eastern and Western Europe profiling rare neurological conditions, that in and of itself has huge value, not just to the pan-European groups that are condition specific, but to the national groups that could be pan-condition coverage. And when you have such a high profile, that in and of itself, you know, earlier before the meeting, we talked about a sort of a PR approach, but it adds huge value to people living with neurological conditions and their families. And something that we didn't touch on, and it nearly come up earlier, is more, I don't want to say the survivor's guilt, but the family members who may be associated with an inherited condition. And in Ireland, we have a lot of people who live with inherited conditions. There's a huge body of work to do in reducing stigma. That is a communications PR piece. And I don't want to say it costs nothing, but it doesn't cost a 10 million pan-European budget to achieve some of the benefits that we want for all of our communities effectively.
As a short comment, in my country, Czech Republic, we pushed through, I was working with a group of patient groups at the Ministry of Health, and we pushed through definition of patient organizations, and who gets into the definition, which is not very tricky to do, but you have to be a real patient organization, not a pharma industry outlet. Then you actually get money from the government. And, we were lucky enough to get some money from the Nordic funds. This is the specific funding from the non-EU members who somehow have a reason to fund us. So these things are, I agree, they are not very costly. They help a lot. And they also help the patient to get through the hurdles of the system, even if they are entitled to care. They need some lawyers to push them through. And we have many volunteer lawyers who are doing this. So it is a great idea. I think part of the implementation of every directive should be, well, who will be actually taking care that it gets to the people. So in cross-border directive, if we add some budget funding for actually making it happen, it would make sense.
Thank you. Tonya, you have the finger up button.
Yes, I was just following up on your reasoning here that people with rare neurological disorders not only get discriminated against in the healthcare system, but also in the mental health care system. One of my biggest problems right now is I'm referring patients to mental health care systems, but they get rejected. Because they have mental symptoms that coming from a neurological condition, and they say that then it's not mental health. So the implied attitude is that people with these kinds of diseases, they suffer mentally, and there's nothing we can do about it. When that is not true at all, and that is also an attitude we have to work on with. The mental health portion of healthcare as well, and turning that around.
I just want to say, maybe if I can give you an insight, most of you probably don't need it, into the life of the bubble here, the Brussels bubble, and how the MEPs can work for you, right? And how national politicians. So Ireland is here on the western flank of Europe, and of course Brussels is here. Now, you might think, because I'm on a committee called Internal Market, which is to do with business and making sure the internal market works, that I'm automatically linked in to the Department of Enterprise and Trade in Ireland. I'm not. I just want to explain that to you. Or you might think if I were on the Sant committee, which I'm not, but just let's pretend I am on the Sant committee here, that I'd be automatically linked into the Department of Health in Ireland. I'm not. Now, the reason I'm saying that is because it makes it very difficult on your groups coming from national sovereign countries and then coming to an umbrella, if I could call it that. Sorry, it's a bit a reductive term, but a European umbrella body. But I just want to say that it's very important that the disparate groups under the sovereign nations do have a cohesive, trusted umbrella group that you can hand over authority and permission to work on your behalf here, because they can't do all the sovereign stuff no more than we can. I can raise issues with my sovereign government in relation to health, and I have in relation to, for example, our conference coming up and so forth. But it's very difficult to have that cohesive voice approach. And what happens is, I frequently find with any issue, it could be neurological conditions, it also could be rural transport. throughout all of this. We just take something, a day-to-day thing, to try and get public transport, rural transport. But they end up not knowing how to advocate because they're coming from their own national country. That's why I would say your first port of call should be to get a budget for a professional body, because the volunteers will run out, the volunteers will die, God forbid, or they'll get sick, okay? And I think your condition is not like cancer. The conditions that you're advocating for are not like cancer. So it's very easy, I think, for the medical institutions and the medical departments, whether it's in sovereign state or whether it's in Europe, it's very easy to say, oh, cancer. We can get the information and the data for cancer. It's simple because GDPR isn't as stringent. But if you take the data that you require, and you spoke so well about, for people suffering from neurological conditions, the first thing people are going to run from is assistance, and the assistance that might be required from somebody to say, well, I do have a neurological condition, but I have to think about whether I want to hand over my data. So I need assistance through the courts, and whether that's a guardian system, and it depends on the legal system and so forth. So there are added difficulties. Somebody mentioned the law down there. Was the good doctor before he left? And he said, you know, was it your good self MEP? But you said the doctors really don't want to know about the patient groups. I would agree with that until it comes to the law. So what I saw as a former lawyer was an advocating for people with infected by hepatitis C and so forth, was that the patient groups only had a very significant function if we were going to the High Court, you know, and if the patients had to be dealt with in the context of their case being put forward at the High Court. So I suppose what I'm saying to you is I'd like you to understand the weaknesses of the political system, the weaknesses, the inherent weaknesses. And I would say, of course, we can help you on budget, we can help you on other lines that you will need help on, and other committee lines in making sure that you are present, you are heard, and that you're funded. But I think at the very, very basis, you need a professional group. It's a professional group that you need of a full-time person on a salary, full-time team, preferably with somebody with a medical background and somebody with a legal background. You know, you're going to need the law and you're going to need the medical. And that's very difficult, but it's not a tall order if you consider how other diseases are treated throughout Europe. I'm picking cancer, but I don't speak with any knowledge about how cancer is dealt with. But I do know in Ireland, cancer patients are very well looked after, and there's a lot of data and statistics about it, and it's there already. So if we could take a leaf out of a book of another disease where they're doing well, and say to the Commission, DG Sant or whatever commissioner from their home countries, this is what we want. This is what we need. And additionally, we also need assistance, whether it's the assisted decision-making process, I don't know what it's called in your own home countries, but in Ireland, it's assisted decision-making process, and other aspects, such as you spoke about, the fact that there's rejection when you're trying to refer your client to your patient, and you're told, well, sorry, it's not classic mental health or whatever. They didn't say that, but it seems to me they're saying it doesn't come under the classic definition of mental disability or ill health, but because it arose out of a neurological or a brain injury. So that's very wide-reaching. But I'd just like you to know as well that MEPs and politicians, because we meet with a lot of groups, and some of them are not on our committee lines, so we're all slotted into committees, and I'm not on the Sant committee, for example. We like to deal with one umbrella group that you trust, but that we know is trusted, and that we know has got the patient a voice there as well. And then we like to be tasked to do something, to be specifically tasked.
Thank you for that challenge. No, thank you.
It's a bit long-winded, but
no, but we understand. We understand that. I think we understand the fragmentation and the puzzle, and how difficult this is, and the different levels and everything. And that's why we also are here to have this communication with you, to try to see how can we navigate the best possible. Because we have some clear asks, I think I can say. So again, just to emphasize the last thing I brought up, please help us, enable us to play the role that we can play and should play and are asked to play. So that's one thing. But the other thing is, please also promote the thought of a joint brain health plan on the European level, because that's something that could help us harvest these synergies and do use of the data and everything in that context. So that's one major thing. And under that, please resource the reference networks, because they play a major role in how services and knowledge is both, built up and improved and shared.
Exactly.
So they are a very good tool. They are there, but they need more resources and kind of more clear priorities, and maybe also assignments of tasks for how to develop guidelines and stuff like that.
Yes, and just one final point. I mean, in an ideal world, and maybe you do have this, but I'm not presuming that you do because it's very costly. But in an ideal world, groups like yourselves require a policy person here in Brussels who is a lobbyist, who is a professional lobbyist. That's a very trite word, but it's actually a professional advocate. So that's where everything begins in Brussels. Now, please,
Excellent.
there's another MEP to talk to you.
We have a colleague, Tomislav Sokol, welcome.
Hello, Thomas. Hello, welcome.
Welcome.
We were speaking about the data space, so I think you arrived just early.
So
a few words on that, perhaps. What's the progress?
Okay, no problem.
Thank you so much.
So yeah, so I think so, but the topic is general rare disease, right?
Yeah, let me help you a little bit to set you into the context. And thank you so much. Thank you so much for coming here. And
I shake your hand.
Yeah.
Thank you, everybody. A virtual handshake, and thank you to everybody.
I know that you are running from things to things, and it's much appreciated that you take the time to come in here. So we have had a quite lengthy discussion actually on the rare neurological conditions and the mental aspects of that, and that there are many different, building blocks, I would say, that needs to come together to really harvest a better outcome for patients in relation to how
Okay,
care is provided.
but maybe since I'm not a specialist on that, maybe I'll just say a few things on what we are doing in the EU on what EU can actually do, because people often think that EU can solve all the problems, but actually most problems are settled or should be settled on the national level. So what, for instance, what will be funded, which national treatments, etc., what will be funded by health insurance, what way how health system will be organized is decided by the member states. So you can support, can help, can solve some things, but we cannot solve everything. So I think that's the first message. So what we are doing concretely on rare diseases and on data. So on European health data space, so the idea is two things. The idea is that we create a common European application with all of our health data. This will be so we'll decide which of this data can be shared with which medical professional, etc. We can also limit access to the medical professionals. For instance, if you have a mental health condition, you can put in a limitation that your general practitioner doesn't see that, or your, I don't know, gynecologist or whatever. So you will be able to control the data. But the idea is that when you go to a doctor, whichever doctor anywhere in the EU, that they will be able to see in their own language your health data and give you diagnosis and treatment much faster than it is now. So that's the idea. For instance, if you are in Flanders, but you're going for a business trip to Brussels or Wallonia, then you have to go to a doctor. They will be able to access your data, see everything that you have, what is important, and give you diagnosis or treatment much faster. That's the idea. That's the so-called primary use of data. This is European health data space. And this will be common European format wherever you go in the EU. So in all countries, it will be the same. So that's the point. There's a so-called primary use, also secondary use. So all the data sets in hospitals and research institutes, etc., that are not systematized, that are not cataloged, will be cataloged, systematized. This will be publicly available. So and those who want to do research on that, for instance, on brain health, will be able to access any of these data sets if conditions are fulfilled. So, for instance, you are a Belgian researcher, you're doing research on brain tumors. You see that there is a data set available in Rome that can help you with patients there, etc. Then you make a request to health data access body in Rome, in Italy, to give you access to this data. And if they allow you, you'll have to state the purpose for which you're using this. And if they see that this purpose is one of the purposes which are allowed, then they will give you access in a secured environment to do research on this data. So that's how it should work. And those patients who don't want their data to be accessed will be able to make an opt-out of the system so that their data cannot be used by anybody else. So
Can I ask you, because I have heard about this for a while, and where are we in terms of having it realized?
The deadlines for the whole thing to become fully operational is in the next 4 years, let's say, because it will require a lot of investments, a lot of preparation of health systems. EU should prepare the budget for that as well, and they're not doing that, unfortunately. They're actually cutting the health budget in the next 7-year proposal, but that's a different story. But yeah, so the idea is to prepare the system, the professionals, health insurance funds, hospital managers, the patients themselves, that they for it, because if you do come with this to patients without any preparation, without any information, people will say, I don't want my data to be used by, I don't know, Facebook or Google or whatever, to make algorithms, social media, profiling, etc. So one of the things that we were particularly careful was to define concrete purposes for which data can be used, especially that it cannot be misused by big tech companies. That is one of the big important things. So that's on the data. On rare diseases, where are we now? So what are we doing? So first, we are doing the Critical Medicines Act. The idea is to make available, there are two objectives actually. First is to become less dependent, reliant on imports of medicines from India, China, and the US. And second is to make these medicines equally available in all countries. So for us, the first step that was very important, and I insisted on that, is that all orphan drugs are included there. So that all orphan drugs will benefit from everything that Critical Medicines Act will bring. And it will bring faster procedures for building factories, for building new or increasing production capacities, or creating new capacities for orphan drugs. So it will go much faster. This is a strategic project. So now every project to build capacity for orphan drugs will be considered a strategic project. If we are able to push this through, of course, if member states have their way, we will not be, but this will be a big fight. So that's the first thing. Second, the European preference. So to reduce our reliance on imports of medicines from other countries, which especially in crisis is problematic, we put European preference. So those companies which produce at least 50% of their medicines, either active ingredients or final products in the EU, will have preference in buying medicines in the EU. That's in public tendering for medicines. So that's the second thing. The third thing is joint procurement. So especially smaller member states will be able to come together, at least 5 of them, and negotiate with big pharma companies jointly as a group, as a bloc. The idea of that is for them to get medicines faster, especially orphan drugs, and to get it cheaper. That's the main point. Because if you are one small country like my country with 4 million people, then your bargaining position with big pharma companies is not that strong. But if it is 5, 6, or 7 countries together, it's a different story. And the third thing is that in case of shortage of a certain medicine, because of stockpiling, for instance, German stockpile 6 months in advance, and there is a shortage. So first, that we have control on the European level of stockpiling to prevent this from happening. So that on European level, we can say, look, you cannot buy all the insulin for yourself or all the drugs for certain brain disease. You cannot take everything for yourself, so you have to limit that, so that others can also get it. But if a shortage occurs, that the big member states will have to share with the small ones. So that will be a big breakthrough if we're able to push it through. So we have a shortage of a certain orphan drug in Slovakia or Bulgaria. We see that because we have exchange of information that if it's available in France and Germany, they will have to send it there. So that's the idea. That's the idea on that. So if you're able to push it through, that will be a major change. Next, cross-border healthcare. So we are making a so-called own initiative report, that's not legislation, but it's a kind of pressure on the Commission to make some things because we state what the Parliament wants on simplifying the cross-border healthcare rules. Because if you want to access healthcare abroad, if you cannot get adequate treatment in your own home country, for instance, certain special rare therapy that's available only in the 2 or 3 countries, you have 2 sets of rules, but they are so complicated that you have to be an expert in health law to know what your rights are. So the idea is to simplify things, to make it easier, to use European reference networks actually for the so-called right to second opinion, and also to inform the patients better about what their possibilities are. Because I know some cases of certain brain tumors where people couldn't get treatment in their own home country, or the treatment was invasive operation, which could lead to many side effects, etc. While on the other hand, you had brain stimulation available in Germany, for instance. And then, so that in these kinds of cases, you're able to get access to the treatment abroad, and that it is paid by your conscience. So EU law gives you that right, but it's so complicated that it's very hard to do it in practice. So we need to simplify this and inform patients about all of it. So that's important thing. And the final thing, obviously, I want to structure all of this into one big plan, into one big strategy for rare diseases and for brain health. So we want to do both. So with concrete objectives, concrete measures, concrete funding, most of the funding, and concrete benchmarks how we measure the actual outcome, whether we are able to achieve things or not. And as I said, the most important thing is the fund, and it will be the biggest problem. So now the Parliament will make this report where we will propose and state that we need to have a rare disease strategy and brain health strategy, and then we'll use this to put pressure on the Commission to actually do something.
Will it happen this year? So it's interesting.
The initial report will be this year, and then we hope in the next year that we'll have the strategy. We actually did this before with the cardiovascular plan, and now we have the cardiovascular plan. So actually, when we put big pressure on them, they actually do deliver. Even though I think the heart's plan, cardiovascular plan is pretty weak, but that's the difference. But still, so we'll have to put, but we'll push strongly for that. We'll put big pressure on them, and we'll also push for a separate health budget in the next 7-year multi-annual financial framework. Because now in the new proposal by the European Commission for the next 7-year budget, nothing for health is ring-fenced, nothing is fixed. So it can be 10 billion euros, or it can be nothing. So that's what we want to change. So this is what we will also pressure.
How do you feel the political winds are here in the Parliament in terms of having support these about the brain health plan and
yeah. Well, it depends on the politics. I mean, in the health committee that we are in, everybody supports that. So in the health committee, everybody supports that. In my political group, it will be a big fight because not everybody sees this as important. But since health is one of the EPP's main policies, there I think we'll be able to get it through. Mm-hmm. There is, I think, more acceptance of that on the left part than on the right. Mm-hmm. Because some far-right parties or right-wing parties usually say that health is national competence, that the EU should not interfere too much on that, like ESN, etc. But we'll see. So it's hard to predict. I say more support for the budget, health budget on the left and on the right, but we'll see. We'll fight for that.
Okay. Interesting. Thank you, Mark, so much for sharing this and for coming here. And we are a little bit over the time, actually, but I would love to ask our esteemed speakers, I would say, to have a final, just one sentence, maybe. Sorry, you have to leave.
Yeah.
Thank you so much.
I think it's said more or less everything. So.
Thank you so much. Thank you so much. Can I ask you, Lut, do you have a final statement or a sentence?
Although life gives you a lot of issues, life is worth living. Whatever. Yes.
Thank you. That's a good statement. Derek?
I want to come back to a point that was made earlier, and what I want to say is that patient organisations, such as the Huntington's Association of Ireland, are in fact more informed and are better experts in their disease areas than many of the professional people in the country. So they would have more of the knowledge, and that needs to be utilised much better.
Thank you. Tonya?
Yes, well, I would like to say that both my clinical experience and the research also supports that quality of life is more important than, and psychological factors are more important than severity of the symptoms of the neurological condition. So you can have very severe symptoms of your condition and very good quality of life. So this is a very important point of intervention. And it's also, my patients don't require that much of an effort. Actually, my neurological patients are my easiest patients as well. So with little effort, you can change a lot for my patients.
Yeah. Thank you. Great. Katarina.
Yeah, I was wondering about what Derek said. So it's not my idea. Yeah, no. I think the NGOs have to be more empowered to do things from the national level to the European level, because we are doing a lot of things for the patients. So we are having a lot of knowledge about the disease. So we are good resources for the medical part and for the government and for the other authorities.
Thank you so much. Rola.
I think my take-home message from yesterday's meeting, if I can, and today, is that when you have a group like this of multi-stakeholders in the room with the MEPs, they're very good at telling us what they can do for us and how they can support neurological conditions and rare neurological conditions. But that they are even getting better at telling us what we can go home and actively do at the national level as well, and the condition areas that we represent. And that's really good synergy to have with this relationship, and I hope it continues. Thank you.
Thank you. Thank you, everybody. I think we Thank you for holding out. We have had a long meeting, 2 hours and 10 minutes actually. So so that's good. But it's really, thank you. Are there people online still?
Yes.
Thank you so much. You are really the heroes to be able to maybe not see us so well, but hopefully hear us and to follow this discussion. So we should wink to them and say bye.